everybody. Hello dear colleagues from Urine Reconnect Centers. I'm very pleased to discuss with you the result of new project and perspective regarding targeted therapy and biologics in Sjögren disease. I am Professor SEROR from Bicetre University Hospital at Paris-Saclay University. Here are my disclosures, mostly in link with Sjögren. First of all, I would like to remind you about the scores that we have in the pocket to assess treatment efficacy in this disease. It will help to explain the trials we will discuss thereafter. As you all know, Sjögren is characterized by a tropism for exocrine glands, which result in dryness feature, mostly mouth and eyes dryness, but also dryness of other mucosa. Apart from this, patients present really frequently with fatigue and pain, and also part of the patient will present extraangular or systemic manifestation that make all disease severity. And when we developed the tools for evaluate Sjögren disease, we decided to develop two tools, one for the symptoms and one for the systemic manifestation, because they are not correlated, and we will see that thereafter. So we have a tool for evaluate systemic complication, which is the SDI, which include almost all possible systemic complication in various organs and assess the systemic disease activity. We have also the ESPRI, which is a PRO that focus on dryness, fatigue and pain, a VAS for each of the three symptoms, and the score. The total score is the mean of the three VAS and range from 0 to 10. How we can interpret this score? For the SDI, 0 reflects a patient with no systemic complication or no actual systemic complication. The low activity stage is from 0 to 5. From 5 and above until 13, it's moderate activity, and then above 14, it's high activity. The MCII is an improvement of 3 points. For ESPRI, the patient acceptable symptom state is below 5 and the high level of symptom is above 5. And the MCII, the minimal clinically important improvement, is 1 point or 15% of the initial score. This is important to interpret the result of the clinical trial, and also to understand the development of the new clinical endpoint, which is the STAR, which has been developed consensually within the Necessity Consortium, which is an European consortium. In this consortium, with more than 70 experts and 100 patients, we developed this score. This score includes all the main domain, the systemic activity, which is measured by the clean SDI, the patient-reported symptom, which is measured by ESPRI, both using the MCII definition for defining response. Then we have the tear and the salivary glandular function, with the Schirmer and OSS for lacrimal function, and unstimulated salivary flow and ultrasound for the salivary gland function. And also we include the biological domain based on IgG level or rheumatoid factor level. To be responder, you have to have 5 points or more, which means 2 of the major domain or 1 major domain and all of the minor domain. We show that this tool was less sensitive to the placebo effect than the SDI alone, and allow to measure and encompass all disease manifestation. And its psychometric property seems to be better than each of the tools used separately. Now, when we have all that in mind, there is another step we have to discuss, is are all patients eligible to clinical trial? First of all, we have to determine if there is different type of patient, and all investigators that see Sjögren in practice know that there is different type of patient. Until now, the stratification strategy that have been performed were based mostly on symptoms VAS for pain, dryness, fatigue, or score of depression and anxiety, HAD, but neglect the systemic manifestation or the biological feature. Our strategy was to include all these variables in the stratification pattern. Thereafter, we identify a subgroup using an unsupervised analysis of hierarchical clustering. We use 2 different cohorts, independent cohort, and we identify 3 clusters in each of the cohorts. It was the same cluster. The first cluster was patients a little bit younger, mostly Caucasian, but with Asian patients, that present with biological feature of the disease, frequently glandular and articular manifestation. They also frequently have high IgG level or rheumatoid factor. The cluster 2 represent patients with systemic feature, with various kinds of systemic feature. They were a little bit older. They include all the men, and they include also all patients with anti-centromere and anti-RNP antibody. And the third cluster was the cluster with a high symptom burden but without any systemic manifestation. As you can see, this cluster is even a little bit older and present with a high level of pain, fatigue, and dryness compared to the 2 other clusters. And if we look forward, during the follow-up, the cluster with systemic feature is the one having the highest risk of lymphoma, followed by the cluster of B-cell biologically active patients, and no lymphoma occurred in the high symptom burden group, which means that we have 3 different clusters. The cluster 1, which is the younger patient, and it's probably an early phase of the disease. The cluster 2 with systemic activity, maybe sometime an evolution of the cluster 1, with a high risk of lymphoma. And finally, this cluster 3, which is quite quiet regarding the systemic complication and could be reassured, but have a high level of symptoms and a big unmet need. Now, if we have these 3 clusters in mind, could we apply the clinical trial to all the clusters? First of all, we cannot apply clinical trial to patients with high systemic activity with highly active systemic complication at a time, because we have a placebo arm. Is it not the right thing to apply the clinical trial to the patient with high symptom burden because they have no biological activity? Maybe it could be done thereafter when we have positive trial for the systemic patient. And then finally, the patient with high biologically active glandular manifestation and articular manifestation is the good target for clinical trial, and we will see that most of the patients include actually in clinical trial. So now about available treatment, we have in France some kind of recommendation, which is the Protocole National de Diagnostic et de Soins. There is also a European recommendation about how to treat patients with Sjögren. This concept is evolving, as you will see, since we will probably in the near future have new treatment. But actually, currently there is no treatment available that has proven its efficacy, particularly regarding targeted therapy. We have the hydroxychloroquine, which is available, but we have a negative trial. This is the JOKER trial. This trial have included patients without any systemic complication, because at the same time there were another clinical trial that were in place in France, which evaluate the rituximab, and all patients with some kind of systemic manifestation were included in the rituximab trial, and all patients with no systemic complication were included in the hydroxychloroquine trial. And in this trial, patients were evaluated based on dryness, pain, and fatigue VAS. And as we can see, in patients with no systemic complication, for treating the PRO, hydroxychloroquine is not effective. But it doesn't mean that it cannot be used in some kind of manifestation like hypergamma-globulinic purpura or inflammatory arthralgia. We have also some data of the combination of hydroxychloroquine and leflunomide, and this combination have been evaluated in two small clinical trials from the same group. This first clinical trial with 21 patients on leflunomide plus hydroxychloroquine and 8 patients on placebo. In this trial, there were an effect on SDI and ESPRI. This have been confirmed for the SDI in the new trial of the same group with a larger group of patients treated regarding the SDI, and you can see the number of responders with the star endpoint. By the way, it is not the case with ESPRI, which is no longer significant in this larger group. This association has also been evaluated in a larger European trial, which comes from the Necessity Consortium, that tests this association and also the association of mycophenolate mofetil and hydroxychloroquine compared to placebo in patients with high systemic activity, but also in patients with high symptom burden and no systemic complication. And we hope to have this result in the next 12 to 18 months. So what are the other available agents? The rituximab. But we know that for the rituximab, even though we have an experience in practice and some open label trial with positive results, there are two major negative trials. The first one run in France that include patients with high level of symptom and evaluated efficacy of rituximab on VAS for pain, dryness, and fatigue. And using this criteria, no effect of rituximab. In the trial conducted in United Kingdom, it was the same. The primary endpoint was the xerostomia, and we have no effect on xerostomia. By the way, in clinical practice, when you treat patients with high systemic activity, with SDI around 20, you can see that there is an effect when compared to historical cohort of patients treated with DMARD. And also, rituximab remains one of the therapeutic options for cryovasculitis, of course, inflammatory joint arthritis that not respond to methotrexate, parotidomegaly, lung or muscle involvement, and some autoimmune cytopenia. There is some issue with rituximab that you all know is that high number of patients with autoimmune disease experience the production of anti-drug antibody and are immunized against rituximab, which is much more frequent than in patients with rheumatoid arthritis. We conducted a study where we observed that about 9% of patients with rheumatoid arthritis has immunization compared to 40% of patients with autoimmune diseases. What we can do in this case, we usually use another B-cell targeted therapy. It used to be ofatumumab. It is now obinutuzumab, which is available and works very well in patients that are immunized. There are other options, such as combination of belimumab and rituximab, and we will come back to that later, which is sometimes used in refractory patients with cryovasculitis. And also, we use very less frequently treatments that are used for multiple myeloma and target plasma cells, such as daratumumab. What will be now the therapeutic of the future, which means treatments that are not available for any autoimmune disease right now? We have two trials that have been conducted and are negative, so we will go rapidly through these two trials. One is focused on abatacept trial, where we see no effectiveness on SDI or ESPRI in two different cohorts. One conducted by the firm all over the world, and one conducted in one center in the Netherlands. We have also a clinical trial that shows that tocilizumab has no effect in Sjögren for treating systemic complication. Compared to the rituximab trial that were negative because patients did not have systemic complication, these two drugs were tested in patients with systemic complication and did not show any efficacy. Regarding positive result, we have treatment that target CD40 and CD40 ligand, which is a co-stimulation molecule of B cell of general center, which play a key role in Sjögren disease. The first is iscalimab that have been tested in a small phase 2 trial, then in a phase 2 dose ranging trial. In the phase 2b dose ranging trial, which is the most recent publication in 2024, 2 cohorts of patients have been included, one with systemic complication and SDI of more than 5, and one with no systemic complication and SPRI of 5 and more. And you can see that in both cohorts, the iscalimab show efficacy of the drug on systemic complication for the cohort A, with an effect on SDI, and on the symptoms, the PRO, the SPRI in the cohort B that included patients with high level of symptoms. In both cohorts, we also observe an effect on salivary flow. This has been confirmed by another molecule targeting the same pathway, the dazodalibep, which is a small molecule, 2 cohorts also, one with systemic complication, and you can see the result here with an effect on SDI and a high delta when we require a decrease of 5 points of SDI of the number of responders of more than 60 in the treated arm and less than 40 in the placebo arm. And also an effect on patient symptoms when we use the SPRI or any of its single VAS, dryness, fatigue, and pain in the second cohort that tested the drugs on symptoms. If we now go back to B cell, we discussed earlier of the use of rituximab in adjunction to rituximab, and the rationale for that is that when you give rituximab to patients, thereafter there is an increase of BAFF level in the blood, which is linked to the fact that there is no B cell and BAFF cannot be stuck by the B cells, but also because there is a positive retrocontrol and an increase of BAFF mRNA that is an actor for the repopulation of B cells, and particularly autoimmune B cells. Also, when you give belimumab, you know that in the month following the initiation of belimumab, we have an increase of B cells in the blood, which are probably the B cells from the tissue that are now circulating. So, this trial has been conducted based on this rationale. You give belimumab to ask the B cell of the tissue to come in the blood, then you put rituximab to kill these B cells, and then you give belimumab after rituximab to avoid the increase of BAFF level. This has been tested in this trial where there is an arm of double placebo, an arm with the sequential belimumab and rituximab treatment, an arm with belimumab, and one with rituximab alone. In this trial, the association of both drugs is the orange one, and you can see on the pattern on the top, which represent the number of B cells in minor salivary gland biopsy, that there is depletion of B cells in the tissue only in the subgroup of patients that receive the association, which is not the case with belimumab or rituximab alone. Also, regarding the clinical efficacy, on the bottom of the slide, you can see that this orange bar is the highest one at week 24 and also at week 68 regarding the efficacy based on the SDI. We have now this drug, the ianalumab, which is in development, which has this dual mechanism of action, a direct lysis of B lymphocyte, but also a blockade of BAFF receptor. And in this trial, which is a phase 2 dose ranging trial, including patients with SDI above 6, we observe an efficacy of the drugs based on SDI, so on systemic complication, but no efficacy on symptoms based on the SPRI. But as for the CD current pattern, we observe an effect with a restoration of the salivary flow and an increase in stimulated and unstimulated salivary flow after treatment. We have also treatment that targeted, which are kinase inhibitors. With the main one and the more promising one is the remibrutinib, which is a BTK inhibitor. BTK is the Bruton tyrosine kinase, which is the tyrosine kinase specific of the B cells. And when you target BTK, you decrease B cell response and autoantibody production. In this trial, we observe an effect of remibrutinib on SDI, with no effect on esprit, but an effect on salivary flow, as we observe with the other drugs. And at week 24, high difference between a treated arm and placebo arm with the STAR endpoint. Another target is not an immunosuppressive, but rather an immunomodulatory agent, which is IL-2, a cytokine, which given as low dose as a regulatory effect. This cytokine has a dual effect. If you give low dose of IL-2, you increase T regulators, whereas if you give big dose of IL-2, you increase the effect of T effector cells. So using the low dose, there are literature that suggests an efficacy of IL-2 low dose in autoimmune diseases, and in this trial conducted in China, it was the case for Sjögren, when you can see here that there is an effect on the SDI, but also on the symptoms, dryness and fatigue, using this therapeutic approach. The last one is the pathway of the FCRN receptor, which is a receptor of gamma globulin, which is implicated in recycling of IgG. And when you target this FCRN, you inhibit the recycling of IgG and increase the risk of degradation, and you are responsible of a decrease of the level of IgG by around 60%, as you can see on the right panel of this slide. And this drug has also an effect on the clinical symptoms and the systemic activity by the clean SDI, but no effect on the patient-reported outcome. This treatment is now in phase 3 for a new trial. And these results have been confirmed by a second drugs that target exactly the same pathway, the FCRN, which is efgartigimod, and this results have been presented recently at EULAR, showing an effect with a decrease of total IgG of 60%, like nipocalimab, and also an effect on disease activity, glandular function, ocular and salivary function, and also, of course, on biological domain. So a lot of trials that have been conducted and are still now ongoing on Sjögren disease, with promising results and hopefully new drugs in the near future. Of course, we cannot talk about the future of autoimmune disease without talking about CAR T cells. And for Sjögren, it's like for other autoimmune disease, trial will be conducted on CAR T cell, and some are going to start all around the world to evaluate the effect of CAR T cell in Sjögren disease refractory to other therapy. In conclusion, there are many new trials focusing on systemic patients with great advance and promising results. These advances could be done by an increased knowledge of pathophysiology, improvement of clinical trial design, existing new score to allow a better evaluation of treatment efficacy, and a better stratification of patients and the way to treat them. So So I would like to acknowledge all my colleagues I work with for years, and thank you for your attention.